Good afternoon. I'm very happy to be here and very much appreciate the opportunity to participate in this symposium. And I too have actually really enjoyed going from the level of the telomere in Luigi's presentation all the way up to thinking about health systems for this very important population. So, but I'm going to start by thinking about a patient, a person who I took care of. When I end up thinking about health systems and population level, it's often, for me, comes back to thinking about how we think about the people who end up making up that group of people. So this is a patient of mine who, at the beginning of the story, was 72 years old. I should say that I'm a geriatrician, but I do primary care 1 day a week in Baltimore in a community hospital that is part of the Hopkins network. So this patient is a 72-year-old woman who lived independently in an apartment, and she was very active in senior center social activities, who the highlight of many of her days was looking forward to and helping plan and then going on day trips on a bus to various sites around the eastern coast. So her past medical history, I think, is pretty typical for patients that we're thinking about in terms of several chronic diseases, as well as having some events in the past that will become pertinent later, including a history of a tubular adenoma and a history of a prior lung cancer. So at the time the story begins, she was diagnosed with a squamous cell lung cancer, which was fairly early stage, and had it resected. As workup for that on a PET scan, she was found to have an additional cancer in her thyroid, which we struggled with, this having been found incidentally, what she should do with it. She did end up deciding to get it resected. So at the time of this study, she was, at the time of this story, she was in a study that was run by Medicare, our big national health care services, where they were focused on whether they could improve quality measures focused on specific diseases. It was a disease management intervention. So she had a nurse who called her from Medicare. So 2 months after the lung cancer surgery for the second cancer, she said, "Dr. Boyd, I have to tell you, the nurse from Medicare who calls me thinks you're doing a marvelous job." And I was sort of shocked and said, "Why?" And she said, "Well," she said, "my sugar level and my cholesterol and blood pressure have never been better, and I've lost 12 pounds. So I really was speechless. Like, I really didn't know what to say because she was so happy. And I, as you all probably realize, was thinking that this had much more to do with the fact that she'd just gone through major lung cancer surgery than any of my care. But then she said, "But I'm supposed to ask you if there's any protein in my urine." And all of these are quality measures that from HEDIS, which is one of the big systems that governs our care in the US. And she was already on an ACE inhibitor, just to note that. But anyway, that's sort of the first part of the story. So about 2 years later, when her hemoglobin A1C and blood pressure trended a bit back up, she said, "Dr. Boyd, I've been putting it off, but I think it's time for my colonoscopy. We have another quality measure that she would be eligible for about doing this." She worries about cancer. She does have the history of tubular adenoma, and she really didn't mind the prep, which are questions that I usually ask patients as I'm thinking about measures that are recommended. So she comes off of aspirin and Plavix for the colonoscopy, which she was on for her coronary artery disease. She was about 15 months after a stent at that point in time, and she presented to our emergency department with an acute ST elevation MI. She emergently went to the cath lab and ended up with angioplasty and remarkably did very well. And as I'm sure you all would be, I was tortured when this happened, that I had done, had I done the wrong thing, had I adequately discussed the risks and benefits of it with her. Just to show you one of these measures. So the colon cancer screening measure is the percentage of the population who's 50 to 75 who'd had appropriate screening for colon cancer. So out of a denominator of people who are that age group. And then you can see listed here the interventions that would have counted for my actually having done it. So as I think about this patient, it really raised the question for me, this story is now a few years old, about how should we really be judging quality of care for this patient in terms of the care that I or provide as her primary care physician, or if you think about her physicians more as a team, and for our healthcare system broadly. So when we're thinking about the care of this patient population, as was articulated by several of the earlier speakers today, when we think about the optimal or best care for this group, we want to maximize the use of therapies that are likely to benefit people with multiple chronic conditions, and we want to minimize ones that they are unlikely to benefit from or that they're likely to be harmed by. But that we have to do this in a way that incorporates the patient's preferences and values regarding burdens, risks, and benefits, so that the same answer is not going to be the right thing for every person. It depends on what the individual wants. So shifting to quality strategies, our Department of Health and Human Services in 2011 developed a national quality strategy, and there are 6 national priorities. And this is for everyone, not just people with multiple morbidity. But so making care safer, ensuring that each person and family are engaged, promoting effective communication and coordination, promoting the most effective prevention and treatment practices for leading causes of mortality, and they specifically highlight cardiovascular disease, working with communities to promote wide use of best practices that enable healthy living, and making quality care more affordable. The Department of Health and Human Services, around the same time, also issued a strategic framework about multiple chronic conditions, and there were 4 main goals that are listed here. I'll draw your attention to the 3rd one, which is to provide better tools and information to healthcare, public health and social services workers who deliver care to individuals with multiple chronic conditions. So within this one, there were 2 strategies that are around measurement of quality of care as a tool to improve care. And so it was through these 2 strategies that Health and Human Services gave a grant to the National Quality Forum, which we then provided some background work for in order to develop a strategic framework for the measurement of quality of care for people with multiple chronic conditions. Just because I'm going to walk through the framework that was developed, but just as a little bit of kind of intro to the way quality works and the framework behind it, just want to draw people's attention to this figure that shows an episode of care. And this is the framework that underlies all the work that National Quality Forum does, which tries to be encompassing of all types of problems people might have in all places people get care, but really is just a way to organize when are we going to measure quality of care. And so an episode of care typically begins when someone is moving into evaluation and initial management. A preventive quality of care measure would begin in this phase. So this can shift. You can shift where you sort of start the episode. This is just one example. So thinking about the way we develop performance measures or quality indicators, it is really important to think about the entirety of the evidence base. And this is where a lot of our work has been focused on, is thinking about this translation. So performance measures depend on really the evidence base, and they often are based on recommendations and clinical practice guidelines. In terms of if it's a strong recommendation, they are more likely to be turned into performance measures, but that is not even necessarily the case in the US. And clinical practice guidelines are built on the way we synthesize a body of evidence and sometimes are able to do meta-analyses, which then also depend on study designs. And we've heard earlier that many times older adults are not included in these studies, and when they are, it's not necessarily in representative numbers, and we're not necessarily designing the studies in such a way that we can draw meaningful conclusions about is there heterogeneity of treatment effect. So I'm going to be focusing mostly on the part about performance measurement, but it really is with keeping in mind that we're trying to base them on the body of literature. So quality indicators are often designed and then implemented for younger populations who may be employed, largely based on guidelines. Many of them are very disease specific, so a specific action or a process for the management of a disease, such as measuring a hemoglobin A1C for diabetes, or a specific outcome of a disease. So is the level, and I realize this doesn't translate in Europe, the number 8 probably doesn't mean much to many of you. This would be the goal, the typical goal for someone who has some comorbidities. So 7 is the lowest goal we usually ever see. There is some recognition that quality indicators should not apply to all patients, which, as we saw in the colon cancer example, may be an age cutoff, or it may be some quality measures have a marker of the person is too sick. That is actually less common than age ones many times, and that our standards are based out of achieving a target out of an eligible population or the denominator. When I think about quality measurement, I'm always thinking about what purpose we're going to use it for. In the US, by and large, quality measures, when they're endorsed by the National Quality Forum, must apply to all different types of purposes. There's no variation in whether some quality measures might be really useful for quality improvement, but perhaps not be appropriate for pay-for-performance initiatives. But I think it's worth thinking about these 3 purposes as we think of designing the best measures. So when we think about pay for performance, what we mean is that there's reimbursement based on meeting the targets in the quality measure. So I showed you some examples that were process and outcome measures in the US. There's also some use of quality measures where we reward the adoption of electronic health records, or how you do on patient experience surveys. So a concern that I have about people with multiple chronic conditions is that depending on what measure is used, that they may become medical hot potatoes, which is the idea that people don't want to take care of this population or are disincentivized from doing that because it is harder to meet the targets. I think this would be a real disservice to the people with multiple chronic conditions. As a geriatrician and a primary care physician in the US, I want more people to want to take care of this population, not the reverse. Patients who are ineligible for the denominator may receive less attention. So most of our quality measures are focused on the population under age 75. A lot of them have exclusions for people over the age of 75, which may mean that we're not harming the people who are over 75, but we're not really being incentivized to do what they need, if that makes sense. If we exclude people from the denominator, it may be easier to achieve the target, but this sort of depends on how the financial reward is set up. In the US, there's not an option in many measures to make a choice to exclude someone. It's really on the basis of the criteria that are listed. And overall, there's not been, in the US, a whole lot of incentive to figure out what is high quality of care for this population. So next we're going to hear from Martin Rowland, who is an expert and led much of this work. But just some lessons that we can learn from the quality outcomes framework in the UK is that it did improve, make some improvements in quality of care, but this was within the context of a number of initiatives on quality improvement in the UK. And quality of care for conditions that were not included in the framework also continued to improve, but at a slower rate than prior to the initiation of the QOF. And there were some unintended consequences. So for example, a progressive decline in the ability of patients to see a GP of their choice, in part because there was a big focus on getting people rapid access to care, which might mean you see someone else other than your preferred person. Stuart Mercer showed this slide this morning, so I won't spend much time on it, but really I think as we think about quality measurement, we want to move from things that are related to specific diseases and to be thinking about multimorbidity existing within the context of a person in their life. So thinking about my patient, what she was measured by at the time are disease-specific measures. And there might be some ways to make these more appropriate to her. But we might think that there are some non-disease specific things that might have been truly the most important thing to measure. So had I had a good conversation with her about the risks and benefits of doing the colonoscopy, for example. I'm going to shift and tell you about the framework now for the National Quality Forum, but just before I do that, I want to do a little bit of lead into the definition that we used, not to add another definition to the mix, but I just think it's important for understanding the framework. So first I'm going to show you some work from Amy Kelly, who's a geriatrician at Mount Sinai, which what this illustrates is that the way we often operationalize multiple chronic conditions in the US would be represented by the blue to some degree, or people who have a functional limitation. And it's really just to note that it's really the people who have multiple chronic conditions and something else, either functional limitation or very frequent health utilization, that really makes them at high risk of a future admission, more days in the hospital, and mortality. And so that chronic conditions alone can pull some people in who have relatively less severe diseases. So for example, sometimes when it's operationalized in the US, hypertension and hyperlipidemia would get you the 2+ conditions, which is probably not the same as someone with heart failure and dementia. So the definition that was used by the National Quality Forum was people with multiple chronic conditions that have 2 or more, but that they collectively have an adverse effect on health status, function, or quality of life and require complex management, decision-making, or coordination. So the guiding principles that arose from this work in terms of informing quality measures is that they should promote collaborative care amongst providers and across settings at all levels of the health system, and that we want to assess quality of care as defined by the Institute of Medicine, which would include many types of measures, both processes as well as outcomes, as well as things like appropriateness of care. So if we end up screening too many people who are too sick to benefit from something, that would be a sort of an overuse type of quality measure we might want to consider. We should think about prioritizing the measures of care, because conceivably someone with multiple chronic conditions could end up having a much longer list of quality measures that apply to them, and not all of them are equally important. That measures should assess if a shared decision-making process was undertaken, as a recognition of the idea that what someone's goals or wishes are may drive what truly is the best care for them. And that we should be able to assess care longitudinally and over time. So rather than just trying to reach thresholds, that we should be thinking about measures where what we're looking at is change over time or maintenance of something. Measures should be as inclusive as possible. So rather than excluding individuals from multiple chronic conditions from many measured denominators, ideally we would have measures that actually apply to this group of people. But when we do need to exclude them, we may need a sort of complementary measure. So if we are excluding people from the colon cancer screening measure, we might want to measure a measure of inappropriate or overuse of colon cancer screening in people who are either much older or much less likely to benefit. We heard a lot about what do we really mean by aging, but I think as an age cutoff is probably not the best way to think about who should be in and out of a denominator. It works for some things better than others, but it may be too crude of a measure. And that we want to use risk adjustment for comparability with caution for outcome measures, and ideally not process measures, which are the did you do something as opposed to how did the person do as a result. and that ideally we'd be able to capture these inputs in a standardized fashion from multiple data sources, particularly with, there was an interest in patient-reported data. So this is the framework that resulted from this work and those guiding principles, and so I'm going to take a minute and walk you through it. This is a person in the middle who is living with overlapping conditions that affect each other to different degrees, but within the context of their life. And so then this wheel is all the sites and providers of care that are relevant to people with multiple chronic conditions. And then the next wheel is the types of care that might be relevant. And so the idea is that these would spin, and I'll show you in a minute, so that different things would potentially line up as you figure out what measures should apply for people with multiple chronic conditions. And in the third wheel are the 6 national priorities for improving quality of care that I spoke about earlier. So being person and family centered, patient safety, effective communication and care coordination, affordable care, health and well-being, and effective prevention and treatment. So for any individual person, different measures would apply depending on where they've seen and what type of care they need or are getting. So these are those 6 domains of measurement from the our national quality strategy. And I'll show you some examples. So non-disease specific measures could apply to all patients regardless of what conditions they have, and that we may want to risk adjust by socioeconomic status, or we may vary which ones apply by age. This would be for outcome measures. For disease-specific measures, a patient may fall into the denominator for multiple conditions, and that ideally these would be prioritized based on what the patient and family wants, and so that we wouldn't just treat them all as equally important. So we can look at performance measurement over 6 months across all 6 measurement domains, and 6 months is sort of an arbitrary time period. And so for each measurement domain, there would be both kinds of measures. So this is thinking about a case example of someone and how they would fall into this population level measurement. So if we have a 60-year-old woman who's got fatigue and weight loss and has significant chronic conditions of heart failure, diabetes, and hypertension. So she received care from a primary care physician, a cardiologist, a spousal caregiver at home, and a pharmacist in the pharmacy. And the types of care that were provided to her were screening, prevention, treatment, and management, or that might have been provided to her, potentially appropriate. And over this stable episode of care, the patient had weight loss and fatigue, but there wasn't any acute exacerbation or change. And so then on the next slide, I'll show you some ways we will line up these types of care with where she's getting it in the quality measures. So when we think about primary care and specialty care and treatment and management, and we've lined those up here, the two domains that immediately come to mind are patient and family-centered care and health and well-being. And so we might think about treatment burden, patient and family experience and satisfaction, goal attainment, encouraging self-management or quality of life of things that would potentially be relevant to her. But that we also might think about depression related quality of life or for her other diseases, as well as hemoglobin A1C, blood pressure, and lipid control potentially being relevant. And I'll just note that the stars here mean that we have existing measures. So this is a framework for the development of measures, not all of the measures that already exist. As we think about patient safety, we might be able to think about measures that would assess the risk of a treatment interaction or the risk of falls, or was medication reconciliation done. And I'll just do one more, and I have more of these if anyone is interested. But as we think about effective communication and care coordination, we might think about measures that relate to continuity of care, care coordination, shared decision-making, how patient-centered was our communication. I'm going to jump ahead in the interest of time. Some key measurement priorities and concepts, as we've noted, are that we want to enable healthy living and optimize function, and we want effective communication and care coordination, and that we want to be thinking about both prevention and treatment, but in a patient-centered way where what their goals are helping drive it, and that we're interested in safety as well as affordability, and that being person and family-centered. As we think about quality measurement for this population, I think we want to always expect and study potential unintended consequences, which requires planning ahead of time to do so. It's challenging because it often requires that we have other measures other than the ones we're incentivizing in pay-for-performance initiatives in order to adequately study this. And just two examples, one is from Martin Rowland, who you're going to hear from in just a minute, which is about whether measurement of patient experience, is it really reliable enough for patient performance? And to me, this is an example of a place where I can really see that wanting to use patient experience for quality improvement, for example, that we could learn something from what our patients and families would tell us, but it may not be the best measure for actually rewarding providers. Just another example, functional status and quality of life are very important outcomes for older people with multiple chronic conditions. We don't have good ambulatory quality indicators that are based on these concepts. There's concerns about usability, feasibility, and validity with this population, and that the people who it's hardest to improve or keep stable their function or quality of life, that in the US, there's already difficulty for people finding providers that will take Medicaid or Medicare. And so the concern in my mind is we have to be thinking about is, what do we do to make sure that we're not disincentivizing people from taking care of the people who are at the greatest risk of functional decline? And so I think there's a lot more research that needs to be done around these measures. I'll just thank my team of colleagues and end us with reminding that when we're thinking about health systems and population level, that coming back to the person in front of us, I think should also be central to these more broader initiatives. Thank you.